Good morning, everyone. My name is Yuli Chen. I am a second-year MPH student from the University of Colorado. My concentrations are in epidemiology and applied biostatistics. And today we'll be sharing with you my research experience this summer in Zambia. My project is looking at the role of HIV infection in cervical cancer prognosis. So first, I will take you through some background information on cervical cancer. Globally, it is the fourth most common cancer among women and also the seventh most common cancer in both men and women. What is striking is that 85% of the incidents and deaths occur in less developed countries. For a reference point, here in the United States, we have 13 new cases and 7 deaths per 100,000 persons per year. And in contrast, in Zambia, they actually experience the second highest incidence and mortality in the whole world, with 58 new cases and 36 deaths per 100,000 persons per year. Here is a table showing cervical cancer incidence, mortality, and 5-year prevalence for different parts of the country, parts of the world. In the second and third line, I have highlighted incidence between more developed regions compared to less developed regions. You can see that the difference is more than 5 times, with greater incidence in less developed countries compared to the more developed countries. And here is a map showing global incidence of cervical cancer. These numbers are per 100,000 persons in the year 2012. Areas in the darkest blue are highest incidence, and the lighter colors are lowest incidence. And you can also see that the dark blues are clustered among sub-Saharan African countries, including Zambia. So cervical cancer is mainly caused by the human papillomavirus, which is found in almost all cases of cervical cancer. Although there are many subtypes of HPV, the majority is caused by HPV type 16 and 18. Studies have shown that high incidence rate of cervical cancer can be attributed to the high prevalence of these 2 subtypes of HPV. In Zambia, the prevalence of these 2 subtypes is 21.6% for each. In comparison, in North America, that prevalence rate is 4.7%. The high burden of cervical cancer is also compounded by HIV infection. HIV is a major risk factor for developing HPV-related precancerous lesions, but also the development into invasive cervical cancer. In Zambia, 15% of the general population and 21% of women of reproductive age are HIV positive. And that persistent infection is also associated with advanced HIV infection, otherwise known as AIDS, which is characterized by low CD4 count. So because of the high burden of HIV, there have been several both national and international collaborative efforts to help combat the HIV epidemic. One major program is the US President's Emergency Plan for AIDS Relief, known as PEPFAR, which is started by President George W. Bush in 1998. The program has been successful in providing antiretroviral therapy to over 7.7 million people in the 15 the highest burdened countries and the most resource-limited countries. In Zambia, PEPFAR is close to meeting the targeted 90-90 goal, which means 90% by the year 2020, 90% of all people living with HIV/AIDS will know their HIV status. 90% of those diagnosed with HIV will receive antiretroviral therapy, and 90% of those receiving antiretroviral therapy will see viral suppression. So they're currently at 67, 85, 89% for each of those goals. This program has also helped to raise some questions in regards to cervical cancer, such as what is the role of antiretroviral therapy on cervical cancer prognosis and treatment, but also provides a structure to implement cancer control and an opportunity to help answer those questions. So upon HPV infection, some individuals may develop precancerous lesions, which are abnormal but benign growth. This is shown as stage 0 in this diagram. In some individuals, these lesions can develop into cervical cancer. There are 4 stages of cervical cancer, and they're defined by both the location and also the size of the tumor. From previous studies, we know that HIV infection is a major risk factor for developing both the precancerous lesions and also development into invasive cervical cancer. But we do not know how the severity of HIV infection affects cervical cancer in terms of progression of the disease, response to treatment, and overall patient outcome. So for my project, I have 3 objectives. The first 2 is working with the databases that are available, linking with the cervical cancer cases that was available from the Cancer Disease Hospital. So this first part of my project is linking cervical cancer cases from CDH, Cancer Disease Hospital, with the National Cancer Registry, and I'll explain why, the reasons behind each of these objectives. The second is linking the cervical cancer cases, again from CDH, with the National HIV database, known as SmartCare, and finally using this linked data set to examine the differences within HIV-positive individuals based on CD4 count, viral load, and antiretroviral regimen. So there were 2 previous CSP students that laid the foundation for this project. The first one is Mulele Kalima, who actually was one of my mentors on the field this summer. His work was calculating observed and expected incidence of cervical cancer in Lusaka and also southern and western provinces. And he identified the cervical cancer cases that I used for this study. And last year, Mario Trejo examined differences in treatment outcomes between HIV positive and HIV negative individuals. So the research site is in Lusaka, right up here, and it's the capital city of Zambia with population about 2.5 million. And the physical office that I was at, as you can see, typical looking office, is in the Pediatric Center of Excellence and was actually a part of the PEPFAR program, and they oversee care and treatment of HIV children living with HIV. My mentors were Dr. Lashimpi, he from the Ministry of Health, and he's also the director of the Cancer Control Program. And as I mentioned, Mulele Kalima, he was also my mentor and a previous CSP student. So this is a retrospective case study so I started with 2,700 cervical cancer cases that was registered at the Cancer Disease Hospital in Lusaka between the years 2008 and 2012. Went through the histology report for each one of them and found 64 that were not cervical cancer, so it was either breast cancer or some other types. 10 were missing age, and because of that, I was unable to, link with the other databases further down in the process. So originally, I wanted to use these 2,600 cervical cancer cases, link them with the HIV database, which has a lot of information in there, including CD4 count, baseline, follow-up, viral load, etc. But the trouble is that this data set here only contained name, age, and the time of registration. It didn't have birth date or any sort of unique identifier. So when I first tried to link them, the best I could do was calculate a birth year, using age and time of registration. And I used a plus or minus 5 years. From that, there was many possible matches without really knowing, what is a true match. So during that last week, in my 10 weeks in Zambia, of course, then I was given a National Cancer Registry data that had not only date of birth, but also national ID number, which is great, but I had 1 week left. So I used name, age, and residence, and I was able to link with the National Cancer Registry. to get their date of birth, national ID number, and not all the patients had these information. In fact, I was able to link about 1,225 out of the 2,600 cases. So from there, then I used that linked data with the date of birth, national ID number. Then I was able to more accurately link with the national HIV database known as SmartCare. And so SmartCare is interesting in that you have to physically go out to the field, collect the database known as transposable databases from different sites. All the sites we gathered, these TBDs, are from the Lusaka province. So I managed to match 147. Matching rate is actually 49% because 868 cases were from Lusaka, and out of those, 302 are HIV positive. And since SmartCare is a HIV database, only patients that are HIV positive can be found in the database. What I did also see is that some patients who were marked as HIV negative in the CDH dataset actually were found in SmartCare, and that goes to show, I think, there's still a stigma around HIV. When they're registered at CDH, they're asked for their HIV status. So even if they know that they're HIV positive, they may not report that because of the stigma. So I managed to link everybody just so I could find those individuals who may truly be HIV positive but be marked as HIV negative in the data set. So since I managed to do the linkage during that last week, I do not have too much results to show, but I did have some preliminary results. From here we can see, so I've categorized the cases into the stage they were diagnosed and also their HIV status, so within HIV positive, negative, and unknown. Majority of the cases were diagnosed between stage 2 and 3. And I think it's interesting that, a good majority of the patients didn't know their HIV status. And if you remember from previously the 90-90-90 targeted goal, only 67% of people living with HIV actually know their status. So I think it's interesting for us to see this high number. It goes to show that that is still a work in progress. I also have their baseline CD4 count, and I have stratified by their stage. And because only 140 patients have a baseline CD4 count, I've also divided into early stage and late stage cervical cancer. In early stage, it's about 50-50 between patients with CD4 count of 200 or greater, and then patients with CD4 count of 200 or less cells per millimeter cubed. In late stage, slightly higher percentage of patients with CD4 count greater than 200. I did manage to calculate an odds ratio, although I have not determined whether or not this number is significant, so keep that in mind. So the odds of having baseline CD4 count of less than or greater than 200 is 20% lower in individuals diagnosed with late stage compared to those diagnosed with early stage. Was quite interesting, but we do not know whether or not that number is significant. So for future analysis that I plan to do is get follow-up. I already have this follow-up CD4 count, but to see how that number changes over time. And also, I have viral load, their full blood count, and do the same thing, baseline, and then see how the follow-up numbers change. One other thing I plan to do is looking at their treatment response outcome based on CD4 count and viral load, and looking at their antiretroviral therapy regimen, whether or not they're on the medication and their compliance with the medication and how that affects their treatment response and outcome. And lastly, looking at the length of HIV infection and how that affects their treatment outcome as well. for future project ideas, this first one was actually my original project that I planned to do going there, and that was looking at cervical cancer screening, how that affects cervical cancer rate. So we know that in Zambia, there is a high burden of cervical cancer, and in 2006, they launched a national screening project. So it'd be interesting to see how that has changed the cervical cancer burden since then. I think it's interesting to see, like in the US, prior to the introduction of pap smear, the incidence rate was 40 and 73 per 100,000 persons per year in white women and black women, respectively. Incidence of cervical cancer in the US in 2012 is much lower, with 13 per 100,000 persons per year. And again, in Zambia, it's 58, and you can see it's between these two rates from the US back in 1947. Oh, and that's an error, that's 1949. So I think it'll be really interesting for a future student to go back and for a project in regards to cervical cancer screening. The reason I wasn't able to do that was because the data is there, and it's a very large database. It's the same structure where you have to go out to the field and collect the sites that you're interested in, and there were some political issues as well, so I wasn't able to get the data due to those reasons. But I think progress has been made. The conversations has been started. Another area would be interesting is looking at cervical cancer mortality, but mortality might be a little tricky because of the sources of data. You might have to, it's not as reliable. So, third idea is to link the databases, again, with the National Cancer Registry, CDH, and the HIV database, SmartCare, for other types of cancers. And lastly, last idea I had was looking at the role of traditional medicine, which is still the go-to way of treating most illnesses, especially in the rural regions in Zambia. So my learning experience, I had lots of experience working with databases, from National Cancer Registry to the HIV database, both paper records, electronic. So I came across a lot of incomplete and inconsistent data, and learning what to do with it, how to deal with it. There was, not really a negative thing, but there was definitely a lot of data to go through to clean. I definitely had to learn SQL coding, which I did not know previously on the field, and that became really helpful. This was a challenge, but I think the future is bright for that project. And I was lucky to have a very supportive team. Up here is Dr. Lishimpi I mentioned before from the Ministry of Health. That's Mulele, and this is Dr. Solomon. Down here, Mario is seated, and also Alec, who helped quite a bit with when I first started learning SQL. Okay, so strengths. Again, I think using the National Cancer Registry that was available helped me to create a more accurate linkage between CDH data and SmartCare. I think the electronic database is actually quite incredible for Zambia, and so that's definitely a plus. There were many variables that was available to me. There are certainly some limitations as well. For example, the limited number of linked CDH cervical cancer cases to SmartCare, but we are also in the process of getting more of those TBDs and possibly increasing that sample size as this project continues. The treatment response and outcome is only available for early stage cervical cancers. I'm not able to look at the response to treatment for the stages 3 and 4. And lastly, there is no real control group. I am only looking within HIV positive individuals, comparing their CD4 levels, so I don't really have a true control group, which is a limitation to this study. As for my future career plans, so my living situation, I lived like a local Zambian. But the area that was the house I was living in had many dogs, and I'm a big fan of dogs. And I was contemplating about bringing this guy back in my luggage, but I didn't. So I would love to work for a federal governmental agency, CDC, NIH, NCI, or others. I'm interested in the role of infectious disease in cancer epidemiology. Because I think it's interesting that as the world is moving away from infectious disease and we're seeing an increase in chronic disease, that overlap would be really interesting to further investigate. And the big question is, do I need a PhD? So if you have any insights, please let me know. It's always, if I do need one, I will, but I think I'm done with school for a bit. And I'd like to thank, again, CESP, Dr. Solomon, Dr. Lishimpi Mulele, Mario, Dr. Labella is my University of Colorado advisor, and Alec Chuba, and of course, CUNY. This picture down here, so I did some traveling to get the data, so I traveled out to the different rural sites, and this is actually what a clinic looks like, not in Lusaka, so it's just a building. And then every time I visited these rural areas, I always get a bunch of kids following me, as you can see here. So with that, I'm open to any questions that you might have for me.
Opportunity to interact with Grospec Parham, who's doing the screening program there, and I don't know what kind of database they have produced.
So the screening database are site level, and they're Excel spreadsheets for each kind of site, and you go out and collect it, and then it becomes, because there's so many sites now, it becomes quite overwhelming to collect all of them. But yeah, they're Excel spreadsheets.
But what sorts of rates of cervical cancer are they detecting in those screens? Because obviously most women don't have cervical cancer.
Right, and that's one of the I wanted to answer that question was with my original project, so I do not know exactly what rates that they're detecting. So, but it'll be interesting to find out.
So that was an excellent presentation and really nice work in a difficult area.
Thank you.
I wanted to ask, what's the status of using the HPV vaccine in a country like
Zambia.
in some of the rest of the world?
Mm-hmm. So the HPV vaccine is quite expensive, and because of that, it's not readily available. I think that within the last couple of years, they did launch a program, but it's not as common as what we see here. For screening purposes, they do use visual inspection with acetic acid because it is cost effective, and that's the method that they use. And it's for low resource settings, from literature anyway, it's the best way to detect cervical cancer.
And the second question I have is, did you get any sense that poverty was a big factor in both of these?
Yes.
HIV and HPV.
Yes, and I think, along with education, I think there's a lot more education around HIV since this, the PEPFAR program, and I think they have done a really good job with, educating the public. Cervical cancer is still relatively new in terms of getting the public aware of HPV. There is a lot of stigma around HPV as well because it is a sexually transmitted disease. So a lot of women, there are, they don't want to get the screening because of certain kind of beliefs behind the nature of the disease. But I think, again, education will play a big role in kind of going beyond that.
Thank you. Really nice job.
Thank you.
Do the clinics where they do the cervical cancer screening also implement cryotherapy for low-grade lesions?
Yes, they do. Actually, the goal of the screening program is that it's a one-day visit, so they get screened, and then if it's low grade, they get cryotherapy, or they get referred if it's a higher grade or a later stage cancer. So the goal is to come in, screen, and then get treated. Because if they have to come back, a lot of the times they don't come back.
So this is the big advantage of this type of screening, because you get an immediate diagnosis
Yes.
and possible intervention with cryotherapy immediately at the same visit. So this really does trump pap smear as a screening method.
Mm-hmm.
But I wonder, are data available for the cryotherapy that's administered?
Yes, in the cervical screening database, there is a variable for whether or not that patient got cryotherapy, or whether or not they got referred, whether or not they came back for that referral. So all of that is in that cervical cancer screening database, yes.
Thank you.
You're welcome.
I want to follow on Dr. Chamberlain's point, because there is a lot to be learned in Zambia from the data sets. I think it's a unique resource of having the electronic HIV treatment data. There is plenty of data for cervical cancer screening, the outcome of screening, the referral from the screening clinic or non-referral to the cancer center. There is a lot to be studied, huge data and very rich resource. I would like to comment on the two students who presented, because I think there is a lesson to be learned here about patience and perseverance and resourcefulness, because Yuli was very patient. Another student in this situation would have packed her stuff and returned back to the US, and being frustrated from the incomplete and inconsistent data. And she was very patient in listening to Muleli and Dr. Leshimpi about linkage. She was nonstop going to the cancer registry and getting data from the registry, trying to understand the system in Zambia, and being patient to the last moment. And Wen also was very resourceful in searching for the environmental data and papers published on pollution in Garbaya. She was working maybe 2 other jobs in addition to her original research project, communicating with the NIH. The IRB approval for the Garbaya Cancer Society expired, and she had to renew it. This is not easy for the local collaborators to navigate the system of NIH and OHPR, but she was doing that for them. She was nonstop on the phone with OHPR. And another student in this situation would have said, I'm returning back to the US. The IRB is not valid, and let's follow the rules. But she was very flexible in getting this done, and also in communicating with different collaborators. I think the lesson here is that you're going to a different culture and different people and different collaborators. They could open the door for you if you connect with them, or they could say, we are not forced to do this. They are not getting money from this collaboration, and they are not primarily epidemiologists. So they work with us because they like us, they want to provide opportunities for us, but not because of their primary interest in epidemiology or research, which is not a primary tradition in the country.
I was going to say, another thing I was struck with, that so much, both of you gained so much knowledge of the way you wish the data were. And I wonder, if you framed your paper or whatever is going to come out of this as an improvement project too, is, just the simple thing of putting the birth date would have been so helpful, And so there's probably some lessons that could be applied to the way data is accrued that would help, analyzing the data later on. And that's not just for Zambia, and Egypt,
Right.
it's for the United States
Yeah.
too. The framing it as an improvement project, and I wish we had this, and these are probably easier to get than, they're just people haven't thought of them, so.
I certainly thought about that, and I think for the Cancer Disease Hospital, for example, I think at the moment that they're taking the records down, I don't think they're thinking about whether or not in 5 years somebody would be looking at this data and actually wanting to find some answers to some question. So I think, yes, that would be really valuable to kind of the importance of just writing date of birth, for example, is, I think it's so easy, but it's often missed.
Yeah, I just to follow up on that, I think that one of the things that you folks may not be aware of is that in a cancer registry, the cancer registrars never see a patient. They're only abstracting medical records, and oftentimes it's years after the patient is dead and gone or whatever. And I've actually lobbied with IARC that they need to run a course for not the people who work in the registry, but the people who work in the hospitals or are filling out the medical records, because they're not thinking, as you point out, that this data is going to be abstracted into a cancer registry and some student from Colorado is going to come here and have a look at it. And so there's a lot of missing stuff. There are some rules about how you guess about birthdays and things like that when it's missing. But there's, as far as I'm aware, in all of the places where cancer registries, there's never been a real concerted effort to educate the physicians who see the patients about how their medical records are likely to be used by a registry.
There's actually a technique that they use in business that's called appreciative inquiry. And basically, it has 4 stages. But the first stage is what worked. And even in the most dysfunctional systems, there's something that works. And if you focus on that, you actually can grow it rather than saying this doesn't work and that doesn't work. And you focus on what works. And then the second stage is, supposing you were Rip Van Winkle and went to sleep and woke up in the future and you went to Zambia and it was perfect. What would it look like,
Yeah.
And so that's called the design, the dream stage. What would it look like? And then you design that. You use what works and the dream to design and then deliver what's going on. But it's a really positive way to make change, rather than this doesn't work and that doesn't work and I wish I had this. It's what works, what's the dream, So your PhD, if you don't know, your future could be doing that, is you've got so much experience, both of you, of designing a system that actually gets the type of data that really needs to be gotten. And that would be a huge deliverable to the world.
Thank you for your suggestion.
I want to follow Dr. O'Donnell's. I want to welcome Dr. Joe O'Donnell first from Dartmouth Medical School, and it's a great opportunity to have him with us here, and also Dr. Elizabeth Cantor from Memorial Sloan Kettering Cancer Center. So I want to mention 2 points here. The first point is what Dr. O'Donnell mentioned about your gaining experience. Unfortunately, this grant does not have an opportunity for the student to go back after this learning experience. We try to do it from other sources, but it's very important to have Mario mentoring Yuli and getting her into the system and having Yuli with future students in Zambia. This saves a lot of time and effort and experience. Second point is that the students now, because the program is open nationally to students from different schools, they are developing a network and cohort of students, which is different from having the students from the same university where they meet and see each other every day. So now they are writing manuscripts, and they talked with Dr. Michaelik about submitting manuscripts to JCE about their learning experience and how this experience could be improved and lessons learned from this. So this is also another opportunity for the new students, if you want to share with the previous cohorts who are already continuing their conversation. The experience didn't end with the summer or their cease funding, but they are continuing their experience to work together and report their experience, learning experience, and how to improve it. And hopefully JCE and AECE could also add to this from the mentoring standpoint.
I'm reminded when we're talking about birth dates as a key factor in differentiating various individuals who may have similar names in a database. I think it was in Ghana that we discovered an interesting phenomenon that when we gathered data, it appeared that very few people were in the age 55 to 60 age range, and then there was a larger number, disproportionately large number of patients in the database who were age 60. And after inquiring a little bit of the local people and our consultants, they said, oh, well, you know, in our country, we don't have birth certificates, and people don't exactly know what their birthday is, but certain medical and social services are provided by the government at age 60. And therefore, it makes good sense for these people who are a little bit vague about their birth year to report that they are 60 years old. But had we not stumbled on this bit of local culture, we would not have known this, and it would have been disguised in the database, and we would have had all sorts of strange conclusions based upon these data. So I think it's important to understand what the local culture is. I was a student of sociology in my undergraduate years, and I had a conversation with I think an economist who said, well, you know, sociologists spend large grant amounts to find out the location of all the brothels in a town, when for a $5 tip, any taxi driver could have told you.
I was going to say one thing, and it goes to Amma's points about publishing. One of the things that I'd suggest, if it was possible, is to put all this together in a supplement in the JCE. And I think they would have more power than individual articles coming out, one in this issue, one in this issue, one in this issue, with some common themes about what did you learn, you know. And it's a Journal of Cancer Education, and so the education, you know, is more important than actually the data, you know, of you know, cervical cancer and HIV and stuff like that. So that's point number one. Point number two, I think you're onto something. There's a guy named Parker Palmer who does this, How Do Revolutions Happen? You know, he's an educationalist, and he says there's 4 stages to you know, change and stuff. The first stage is to, he says, become divided no more, is where your actions and your behaviors are sort of resonant. And there's a lot of institutional things that don't allow us to live our actions. You're doing it. You know, all the people here are doing that. So you're divided no more. And that's often a very private thing, and it's very actually, it makes you come back to work. It's, you know, I go to work, it's not work if you love what you're doing, you know, if you live in your dreams and live in and getting meaning and purpose out of it. And the second part of it is you find like-minded people that are doing the same thing. And all of a sudden, you have a like-minded group of people throughout the country. And right now we have stuff, social media and things like that, that can connect you in ways that we never had in the past, you know. So this community of congruence you've produced here with all these things. The next thing you do is you go public. You know, you sort of say, we've really got something here, which could be the issue of the JCE. And the fourth thing is then the institutions change and the world change. And so global health, cancer epidemiology could really change because of this movement of you guys living your dreams, you know, and getting together, even though somebody's from Colorado, somebody's from George Washington, you know, you're doing this stuff that's really important and it can change the world. So.
Thank you.